Hi, this is Barbara Howard here to talk to you about primary care management of teen depression according to the GLAD PC guidelines. As you know, depression is very common, especially with COVID. 9% of teens meet criteria for depression at any one time, 2 to 1 being females. During COVID, it's been as high as 51%. Yet only 50% of teens with depression are diagnosed before adulthood, and 2 out of 3 youth with depression are not identified by their primary care provider and don't receive any kind of care. Unfortunately, even when diagnosed, only half get appropriate treatment, and only 20% of depressed teens access treatment. So while this is something that pediatricians feel responsible for, 46% lack confidence in taking care of teen depression. The symptoms in teens include a range of things that can be confused with other problems, including aches and pains, low energy, changes in sleep or weight. But more commonly, teens might express feeling bored, lacking social interests, or having a strong interest in video games, or feeling rejected by peers. At school and with homework, this can look like procrastination and underachievement, and these symptoms can both be caused by or produce family conflict. Also watch out for school absence. Keep in mind that ADHD symptoms may also be due to mood disorders. You have an advantage being somebody who knows the child and family, is trusted, and doesn't have stigma associated with coming to your office. And the fact that people may come to you for care can also reduce the known racial and ethnic disparities in getting care or having insurance coverage for care. You can also simultaneously figure out and treat physical as well as mental health conditions and provide continuity for monitoring. So the first thing to know is what the definition of a major depressive episode is. So a major depressive episode is one sometimes of many episodes as part of major depressive disorder. So to have a depressive episode, the teen needs 5 or more of the symptoms I'll describe in a minute being present during the same 2-week period and representing a change in function from previous functioning, with at least one of the symptoms being either depressed mood or loss of interest or pleasure. You'll recognize these because they're basically reflected in the PHQ-9 tool, which will be used in this project, including depressed mood, diminished interest, weight change, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness, trouble concentrating, or thoughts of death. Now, those are the same things covered in the 9 PHQ-9 symptoms, but to get the diagnosis, the symptoms also have to cause clinically significant depressed or impairment in social, occupational, or other important areas of functioning, which is something that all the DSM-5 disorders require. The symptoms also need to not be better accounted for by bereavement or a loss, although a loss may hide major depressive disorder, and also not due to the physiological effects of a substance or another medical condition, nor better explained by these schizo and schizoaffective symptoms. The youth needs to never have had a manic episode or a hypomanic episode unless it was due to substance or a medical condition. There are a number of types and codes that go with having a single episode or a recurrent episode and whether other symptoms are present. And the differential diagnosis includes other depressive disorders that are not major depressive disorder, as you can see here, including persistent depressive disorder and other more specific depression symptoms. The differential diagnosis of major depressive disorder, MDD, includes normal moodiness, these other depressive disorders, but also things like anxiety disorder, adjustment disorder, PTSD, or other trauma-related disorders, and a depressive episode of bipolar, which is not included among the depressive disorders in the DSM-5, eating disorders, ADHD, conduct disorders, medication side effects, or medical conditions such as traumatic brain injury. There are also comorbid conditions, which sound pretty similar to what I just defined, but include chronic illness, substance use, medication side effects, and the other things I just mentioned, but also other psychiatric disorders that I didn't mention occur more commonly along with major depressive disorder, including learning disabilities, ADHD, anxiety, eating disorders, substance use, and somatic disorders. Abuse or trauma can certainly cause a major depressive disorder and is among the risk factors, which include a family history of depressive disorders, especially in mothers, which increases the risk by threefold. But anxiety often transitions into depression from early childhood anxiety into adolescent depression. And any prior suicide attempt should be a clue. Lack of social support, stressful life events, substance use, and autism are risk factors, as is gender nonconforming identification, known as LGBT2S+, to include Native American symptoms of uncertainty about gender. Usually, a negative life event related to a relationship has been a precipitant, but that's not always true. Now, the questions that you ask as part of a regular checkup may give you a clue to the presence of a mood disorder, such as anhedonia, if asking about activities reveals not very much, or strengths, similarly, if functioning is declining, if there are physical symptoms, a general straight up question about mood, and certainly questions about suicide. So it's now recommended by the GLAD-PC and the American Academy of Pediatrics that pediatricians ask directly about depression as well as suicide and screen at least yearly for all teens, screening with a depression screening tool. And according to the brand new blueprint for youth suicide prevention, also a suicide screening, specific suicide screening tool, at least annually and possibly even monthly or more somewhere in between those two. Of course, a screening tool is not perfect, so this has to be combined with interviews of the parent and the teen. And it's appropriate to be looking for depression in children who have the risk factors that I've mentioned, and to actually manage mild to moderate depression, mild or moderate uncomplicated depression by primary care providers, while coordinating care with any adolescents who are referred to mental health providers for care. Now, these recommendations come from the 2018 recommendations that were strong or very strong based on expert panels. And some of the components of the GLAD-PC recommendations from 2018 include that primary care providers should get basic science-guided behavior change method training and quality improvement methods being used, which is part of this project, as well as making sure that you have identified referral resources and crisis resources in your community. This includes the nncpap.org, which is a national organization to provide phone consultation to primary care providers in every state. So with this annual screening using a standard tool, that's the first step. And then those with risk factors being watched more closely. So some of the risk factors I've already mentioned as comorbid conditions or as in the differential diagnosis, including a history of previous depressive episodes, positive family history for depression or other psychiatric disorders in the child, substance use, trauma, psychosocial adversity, fostered or adoption status, and keep in mind that frequent somatic complaints or previous high-scoring screens that did not result in a depression diagnosis are reasons to keep an eye on it for the development of major depressive disorder. There are a variety of depression measures. In this project, we're using the PHQ-9 and the Moods and Feelings Questionnaire for the teen and the Moods and Feelings Questionnaire for the parent. It's also part of this project to use a general tool by the adult, the parent, in this case, the Pediatric Symptom Checklist 17 for the parent, but other tools are available for people who are not part of this project or subsequently if you wish. So the assessment should include an evaluation for the symptoms I just mentioned in the DSM-5 or ICD-10 criteria for anyone with a positive screen or if they haven't had a screen, to do a screen, and then to determine the severity of the depression symptoms to decide on subsequent treatment. This will include an interview of the teen alone and the parent looking for functional impairment in different domains as well as other psychiatric conditions. So the domains include school and family life, and the things that can be precipitants include losses of a loved one or a pet, the family history that I've mentioned, other behavioral or physical symptoms, and certainly suicide risk and asking about sexual orientation. Comorbid conditions, we've mentioned substance use, ADHD, and anxiety, organic illnesses, and looking for their enthusiasm for life and their interests. This also helps you identify potential talents that can be prescribed for activation activities to reduce depressive symptoms. It's useful to ask about the greatest disappointment in relationships with parents or peers, because this may be a core piece of subsequent primary care counseling. If there hasn't been a depression screening tool, it should be done. Remind you that medications can produce depression side effects. These are not commonly used, but are possibly used in pediatrics. Now we'll talk about management. So you've now identified major depressive disorder, and you want to establish the severity rating, which we'll discuss in a minute. But then you need to name it and educate and counsel the patient and their family about depression and the options for management, establish a treatment plan and a safety plan. And we'll go into some details about that. So depression education needs to include the fact that depression is hereditary, but also brought out by stress. That can also help remove a sense of blame from the teen or the parents. Sometimes the way the parent has handled the teen's irritability or other symptoms of lethargy may make them feel guilty about it. So it's important to let them know that you've now determined that this is a physical condition, physiological condition, and not their fault. So they need to be supportive rather than blaming. It's important to recognize that this has a course of many weeks or even years and has about a 40% recurrence risk, although the prognosis tends to be good, especially with earlier identification and management, 85% significantly improved, but there is also a suicide risk, which requires keeping a safety plan. You should discuss with them evidence-based treatments, including the possibility of using medication, although it's not always indicated, and reminding them that the combination of medication and for depression and alcohol can be disinhibiting and cause some extra risky behaviors. In terms of self-management, activation activities should be prescribed, as well as regular goals and healthy habits of eating, sleep, and exercise. So the typical major depressive disorder episode lasts about 7 months if not treated, longer if there's comorbid anxiety, drug use, or depressed parents. But 40% will come back within 2 years, especially those with early onset or who have also got dysthymia, which is persistent depressive disorder, or adverse family factors. Dysthymic disorder itself, persistent depressive disorder, lasts about 4 years, but that is not a benign condition either and can be followed by substance or tobacco use, antisocial behavior, and impairment in work or social life, as well as a risk of suicide. So we talked about the organization of the clinical setting, but now we're going to discuss the different treatment for mild depression and moderate or severe depression. So mild depression can be managed, and according to GLAD-PC, should be managed by willing primary care providers if their patients are also willing. That includes a period of active support and monitoring before starting any evidence-based treatment, either therapy or medications. Before those things, weekly or biweekly contact with a primary care provider for 6 to 8 weeks has evidence for being helpful. If the depression is rated as moderate or severe, or there are complicating factors, then consultation with a mental health specialist, especially initially, can be important. You should also provide active support, but you then need to recommend scientifically proven treatments, including CBT, cognitive behavioral therapy, or IPTA, interpersonal therapy for adolescents, and or antidepressant medications, typically SSRIs, and monitor for adverse events during any medication treatment is very important. So how do we decide how serious the depression is? Well, the guidelines, the DSM-5, asks that the number of symptoms as well as their severity and degree of functional impairment be judged, with the number of symptoms being closer to 5 would be mild, closer to 9 would be more severe, with more severe symptoms indicating more severity. The PHQ-9 helps you with some of this, but remember, it's not a score of 5. It's actually 5 different symptoms. So this is the scoring of a PHQ-9. Typically, the cut score for this tool is used of 10. We're using a score of 8 in this case because it picks up more early stage depression that is of clinical significance, even though it doesn't meet the criteria of 10. Any suicidal ideation or acts certainly also qualify in determining severity. So the general components of depressive disorder management include, as I mentioned, education, assuring sleep, nutrition, and exercise, but also addressing family stressors, recommending both parent and patient self-management activities. The parent may be depressed themselves and may need to be referred for therapy. You may refer for peer support, although that's depends on the kid and also what's available in your community, but you certainly need frequent weekly or biweekly visits, especially if you start medication where you need to be watching for agitation, an increase in suicidal ideation, or the emergence of mania, which can be one of the possibilities when starting with SSRI treatment. Active support, I've already mentioned, and be prepared to refer for mental health evaluation or treatment. So mild depression with primary care management only may remit with support in 6 to 8 weeks. You can consider medications in other certain circumstances that we'll talk about later. So here are some of the things that GLAD-PC recommends for active support and the size of their effects. So recommending religious or fun activities, including exercising until out of breath 3 times a week, or participating in things like yoga is helpful. There are recommendations that the teen will get in this project to help connect them to some more specific examples of these things. Balanced meals means something closer to a Mediterranean diet, not junk food. Fatty acid supplements of at least 800 milligrams per day is better than nothing, better than placebo. And encouraging the teen to spend time with supportive people or peers or online support groups. This is one of the ones that will be recommended. To spend time relaxing, including learning relaxation techniques such as mindfulness. The apps of Calm and Headspace can be helpful for that. And we're going to be recommending a chatbot, which is a minor form of cognitive behavioral therapy for the teens if they choose to use it. Setting small goals and simple steps can make the teen feel a sense of progress, and doing things often precedes feeling better. So the focus of your interactions with the teen after making those recommendations is to focus on finding solutions to problems that the youth identifies, which are often relational problems, empathize with their pain, and help them formulate clear, simple, and specific behavioral change plans, and then follow up on those. There is a manual-based treatment that you can learn, and the manual is included in your PST, but it's recommended that you actually get more specific training for that if you intend to be a reliable trainer. Now, if the symptoms of the depression is rated as mild, but it persists for more than the 6 to 8 weeks of active support, or if it's moderate when you first detect it, then you should go straight to treatment. Now, the treatments can be primary care therapy, evidence-based medication, or evidence-based therapy with someone else including cognitive behavioral or interpersonal therapy. You notice these are and/or. So the combination of medications and cognitive behavioral therapy, for example, for moderate depression, has evidence of being better than any of them alone. Now, if there are complicating factors such as substance abuse or psychosis, then a crisis intervention should be initiated. If the patient and family is having difficulties in their interactions, then recommending in-home or skill-building services may be appropriate. And for moderate depression or persistent depression, mental health consultation should be considered. Now, you'll also want to help the teen come up with goals for home, school, and peers, and monitor them in these biweekly or monthly sessions by asking about their depression symptoms, their functioning, their stressors, any signs of suicidal ideation, any signs of mania, which I'll define later, but basically mania shows periods of high energy, high activity, small amounts of sleep, and often risky behaviors. And that can indicate that the teen is actually on the way to having bipolar disorder, or it may be a side effect of medications, which is known as activation. And of course, adverse events that may subsequently occur in the child's life. You should continue active support by the primary care provider, even if they are referred to a mental health provider. And here, with these persistent depression or moderate depression, is a time to establish a home safety plan and go over that with the teen and the parent. If you choose to refer instead, you should still stay involved, having visits to make sure things are going well, but also negotiate your role versus the mental health provider's role and how you're going to communicate with each other. So this is an outline of the components of a home safety plan for parents that needs to be discussed with the caregivers. One is to remove lethal means. It's useful to compare this to having a fire safety plan. And that is, we don't want anything bad to happen, but it's better if you're ready for it. And the other way of thinking about this is like wearing a seatbelt in the car. Okay, we never expect to have a car crash, but if you're wearing a seatbelt, the likelihood of having a fatal car crash is lower. So removing or locking up ropes, cables, guns, and other weapons, sharp knives, and locking up alcohol, medications, including pet medications, and poisons in the house can avoid some serious problems. The parent should be checking in with the teen and asking about whether they're feeling like killing themselves. This does not promote the idea of suicide. So the reason that locking up guns is included here is particularly true because many people who have guns in the home are not willing to get rid of the guns. So they should have a lock separately from ammunition and lock up both the gun and the ammunition. A plan like that, possibly including trigger locks. So those are some things that need to be discussed. The parent should be watching for suicidal behaviors like these, in particular, giving away possessions is a warning sign. They need to watch out for drinking and drug use because those things make it more likely to have suicide occur. And they need to have a suicide emergency plan where the teen themselves have names and phone numbers and addresses for and when to call those, and perhaps take a picture of the plan and keep it on their phone so they have it at all times. There's a separate video about using the Chattis suicide risk assessment worksheet that creates a safety plan for dealing with suicidal thoughts. The kinds of therapy that are available include all of these. Typically, CBT or EPTA are the ones you're going to recommend, but there may be reasons for encouraging family therapy or group therapy under certain circumstances. Now, if the medication is prescribed, but there's only partial improvement after 6 to 8 weeks, that's a time to reassess adherence with the medicines, the presence of any comorbid disorders, or any conflicts at home or child abuse going on. At that point, if there are none of these, of course, you'd address these, but if there are none of these or they're being addressed, then you should increase the medication going at least to the maximum, but even above the maximum dose in the tables that are being provided to you. If they're not in therapy yet, therapy should be added to what they're doing. And again, this is a time to consider mental health consultation, even if you're going to continue to be the main one providing the therapy. So that's for partial improvement on meds after 6 to 8 weeks of treatment. Now, if there's no improvement after 6 to 8 weeks, you ought to be rethinking your diagnosis. All the things I just discussed still apply, but this would be a time to either add another SSRI or change the medications to a different SSRI or to venlafaxine if you are already at the maximum dose of the SSRI or they're not tolerating the side effects. Now, regardless of the severity of the major depressive disorder, if they're improved after 6 to 8 weeks, then the medications they're on at that time should be continued for 1 year after the reduction in symptoms to below the CUT score. Okay, 24 months if this is actually a recurrent episode, not an initial episode. And during that time, you should monitor them monthly. That doesn't always have to be in person, but it should be contact with the patient. And then when they're off medications, you still need to monitor them for 6 months every month. The first 3 to 12 weeks after stopping medicine is the highest chance of relapse. This monitoring should go on even if they're still seeing a mental health provider, although you would want to maintain contact with any ongoing mental health provider. This is the algorithm from the GLAD PC, which is included in the Chattis PST and the basis for this talk. Thanks for listening.